Welcome back. Today we're going to continue with the natural extension of what we talked about in the anatomy of the heart, the cardiovascular system, and begin to look at the vessels as they go from the heart to the rest of the body. First, let's look back at the expansion of the slide I originally showed you of the cardiovascular system. Here we have the heart in the middle, and we have the pulmonary circulation that I showed you last time, the separate circulation from the rest of the body. And then we have the systemic circulation going out the aorta, some of it going up to the head and the brain. A full 20% of it goes out to the head and the brain. And then the rest of the body. Now, before, I showed you the body as one big unit, and here this slide has broken it down into different units, which we'll discuss. There's basically several circulations in the body. We've talked about the systemic circulation going to the organs of the body, and we've talked about the pulmonary circulation. There's also a circulation down here on this slide which shows the venous return from this schematic of the intestinal organs all going back through the liver, where we'll see something called the portal circulation, where we actually go from veins to veins, not from arteries to veins, in an attempt to conserve some of the chemicals and not dilute them. We have another one of those portal circulations in the brain, a very small microcirculation. So there's actually 4 kinds of circulation. We're going to be talking about 2 vast networks, the systemic, the pulmonary circulation. And what happens in these systems, these are closed-loop systems that connect with each other. The heart is the pump at the center, and the arteries at first can be looked at just as conduits. They carry the blood away, and no exchange goes on in those arteries. And then what happens is each of them divides and branches, and we have really what's essentially different streets. We then move to look at the streets themselves. And if you look at the next slide, here's a nice overview, somewhat schematic, but still anatomically correct. We look at the arterial side of this circulation. What we see is the aorta leaves the heart and makes a big looping turn down toward the body. This is called the aortic arch. And it was thought that the aorta actually held the heart up like a shower head. It actually doesn't. The heart has its own integrity held in the pericardium. And it begins to immediately give off branches, as you can see here. Now, what happens is all the branches of the body are going to be named primarily for the place they supply. They are going to be either a supply where it becomes the axillary artery, because the armpit is that it divides at the elbow and it runs along a bone that's called the radius, the place you actually feel for people's pulses very frequently. And it becomes a radial artery, and on the other side, the ulnar artery, because it runs along the ulnar bone. So generally, we're going to talk about the supply to the organs. So we have a gastric artery feeding the stomach, or we're going to talk about the neighborhood. The aorta then travels down through the body. It does very little in the chest. It actually only gives a few branches to the ribs and to the spine. And then when it pierces into the abdomen, it has lots of branches, which we'll talk about in later lectures. I don't want to overwhelm you now with just lots and lots of names, which will have no meaning. We'll talk about the branches as we get to each organ system. And then this very big artery, which by the way is about 3/4 of an inch in diameter internally, that's the size of a hot dog, then divides into two branches and feeds both sides of the pelvis and the legs. What happens in this arterial system is that as it goes on and on, the vessels decrease in size, and it's more than just an anatomic decrease in size. It also is a functional change in size, because we go from what we call large arteries to medium arteries to small arteries, and then down to something called arterioles, and the function changes at the level of the arteriole. The arterioles are the smallest artery you can see with the naked eye. After that, we get into the capillaries, the arterial capillaries. Capillary means hair-like, and these are finer than human hair. You can hold human hair up to the light and see it. You cannot hold the capillary up to the light. It is microscopic. It measures in the neighborhood of about 8 to 9 microns in diameter, and will just pass one red blood cell as it goes along. The other side of that is the venous capillary, and that is a functional designation. There, as we'll see, there's no real anatomic change as we go from the arterial side to the venous side, but now the red cells have lost their oxygen and they're on their way back. And so that defines the venous side of this system. show you the venous side as it is compared to the one we just seen. This is the same picture, and by and large, in most of the body, the names are going to be the same, so that the brachial vein, which is running back toward the heart, is going to be running right alongside and named the same as the brachial artery. There's a subclavian vein next to the subclavian artery. They actually touch each other. Some of them are a little different. We have a very big vein in the neck called the jugular vein, and we have a vein coming up from the legs called the vena cava. That's the equivalent of the aorta going back through the heart. But by and large, this system is something we actually don't even study that hard because the names are the same. They run in pairs along with the arteries, and so it's just a given once you learn the arteries that you'll know the names of the veins. Now, of course, on the venous side, we're going to be increasing in size all the way back from capillaries till we get to the heart. In the general circulation, we have to think of the capillaries as being the part of the system that is involved in exchange. This is really the only functioning part of the system. Nothing happens by way of exchange of gases in the arteries, the arterioles, all the way down till we get to the capillaries. They're merely channels. There are conduits or roadways which carry the blood to the place we want them to go. I mentioned before that this is an enormous system. I would say that probably less than a mile of the grossly visible vessels I'm sorry, that the grossly visible vessels constitute less than a mile of length. I mentioned the number 50,000 miles, which astounded everybody, but that's the microscopic bed. These are microscopic vessels laid end to end, which certainly would comprise that enormous number. It's hard to visualize a number like that as an awfully big number, but it's just important to realize it's immense compared to the arteries that we can see. What's interesting about these vessels is that they are a very important part of the total functioning of the vascular system, which I'm going to get to in just a minute. There's one other vessel you ought to know about. It's called the vasa vasorum, the vessels of the vessel. When you look at these big vessels, such as the aorta wall, which is a metabolically active component and needs nourishing. The vasovasors are visible. You can see them with the naked eye, and they are, again, another system that we don't pay too much attention to because they're just a given. Nothing much goes wrong with them. They tend to be something that stay in the background doing their job without much attention or disease process. The word artery is interesting. It comes from the words that mean to carry air. The early days, 200-300 years ago, when we first either illegally or then legally got the ability to dissect human bodies, a lot of these patients died of bleeding or other disorders, and when they were autopsied, their vessels were empty. So the early anatomists and physiologists thought they carried air, which of course they don't. But that name has persisted. The artery walls, which we're going to talk about, are all different as you go from the aorta all the way down through the arterioles. They're composed of a certain amount of elastic tissue, which gives them recoil ability. They are also composed of varying amounts of smooth muscle. Smooth muscle, as you remember, is involuntary. You have no control over that with your conscious brain. And what you'll see is we have a huge difference between the muscles that have lots of smooth muscle. I'm sorry, between the arteries that have lots of smooth muscle and between those that don't. Initially, the first vessels are what we call conducting arteries. They have lots and lots of elastic tissue, and they have more elastic tissue than muscle tissue. The reason for this is they need to provide that recoil. So when the heart pumps and the vessels expand a bit to the higher pressures that we talk about, as it recoils, the pressure is maintained and doesn't drop off to zero the way it might in, for example, a pipe, an inelastic pipe. As you get further along the vessels, we develop more and more smooth muscle until we get down to the point where the smooth muscle is the major component of those vessels because they're not involved so much in just channeling blood to one place, but in shunting blood to different places. The main function of the to specific organs at specific times and different times of need. These are called distributing arteries, and they're generally smaller than the 3/4 of an inch that we have in the bigger arteries. The arterial wall is a really complex and interesting structure. If you look at this diagram now, we've gone all the way back down to the arterial. Again, this can be seen with the naked eye with some difficulty. And look how it's wrapped in circular muscles all the way down its course in very high concentration compared to, for example, the aorta, which hardly has any. These muscles can only contract in a circular motion, so when they're stimulated, they're going to tend to narrow the opening of the arteriole. They're going to decrease flow through this vessel. Now, if this band of muscles contracted severely, it would shunt a lot of the blood down this smaller arteriole, and would get it to the place we want it to go. Instead of all the blood going this way out that arteriole, it would come down into the smaller vessel and then into even smaller ones until we get to something called the capillary, which is the smallest structure we have here. And as you can see, this drawing is indicating one layer of cells. Each of these is the capillary cell. There's only one of these in thickness on the wall. This you could see through, for example, if you shine light. And there is something called the pre-capillary sphincter. This is a complete encirclement at this point that allows the blood to be completely cut off to any group of capillary. Once the blood is exchanged, we go through on the venous side, and we similarly have some smooth muscle, but very, very little if you compare it up here to the arteriole. Now, this lumen is important because of the gas exchange. As I said, only one red cell will fit through. That means if you have a cell on this side of the capillary and you have a red blood cell here, you have very little tissue for which it has to go through to get to the cell. oxygen can come out of the red blood cell through the wall and then right into the cell wall for exchange. Every cell in the body lies next to a capillary. Every cell in the body. That's why we have this enormous bed of capillaries. I might mention here that there are several different levels of what we call vascularity. Organs that have a great deal of blood supply versus organs that have very little blood supply. For example, the brain has an enormous blood supply. It gets its nutrients, its oxygen, and it also doesn't have any way to store oxygen. It's very, very metabolically active. Any termination of blood supply to the brain is catastrophic in a few minutes. Other organs have much less blood supply because they're not turning over, they're not active, such as bone, tendons, joints, have very few capillaries per unit of tissue, and they have less blood supply because they just don't need it. And then finally, you have a couple of organs or systems that don't have any blood supply at all. Those are two: the lens of the eye and the cornea of the eye, which we'll talk about later. But if you think about it, you would not want blood running in front of your lens or your cornea, which would then blur your vision or color your vision, certainly. Those organs actually are metabolically very, very inactive, and they get all their nutrition and growth requirements from what's called diffusion. Oxygen can come out of the air and nearby tissues and supply them quite well. There's another term I want to talk to you about, and that's called an anastomosis. And plural is anastomoses. You're going to hear this one a lot. Anastomosis refers to the joining of another, and the brain is very unique, and we'll go over that in great detail. If you look at the kidney, which we will do later, for example, there's only one vessel to the kidney. This is called an end vessel. And when you have an end vessel, you have a very precarious situation, because if that gets occluded or blocked, that's the end of that kidney. Now, one should say then, why has evolution done this? Why is this allowed? And the answer is because there are two kidneys. Evolution has given us two each with its own blood supply, and each of which can function by itself. You just need one kidney to survive. Now, on the other side, we have the venous system, and that again is pretty much parallel. Most of the vessels return the deoxygenated blood back, and the venules receive their blood from the capillaries, empty progressively into larger veins until they get to the heart and the superior vena cava. They are thinner walled, they have less elastic tissue, and this has a clinical ramification in that when you get bleeding, people think of arterial bleeding as being really, really serious. Well, the arteries have these muscles. They can actually clamp down and help stop bleeding, which we'll go into in detail in physiology. But the veins don't. And when you get a big tear in a vein, either from trauma or in the operating room, those can often be the most difficult to deal with, and people can bleed to death because of that inability of the vein to constrict. Now, below the heart, the veins have valves which prevent backflow. So as we massage our veins with our muscles, they are able to push the flow back to the heart and get it into the larger and larger veins without having gravity destroy the effect. So if you have the situation here, or this is a representation of a vein going through skeletal muscles, for example, your calf. And here are the valves. When the muscles are relaxed and gravity would tend to pull blood back down toward the feet in the reverse direction, the valves close and prevent any retrograde flow. When the muscles are contracted, they squeeze the blood up. They can't, this blood cannot go backward, it's still, and the blood can go upward back toward the heart the way it goes. This can actually become a problem when you think about it if there is prolonged inactivity or failure of the muscularity to contract. Patients or people, for example, who are on an airplane for long periods of time, sit with their legs hanging down, may not get up, and the blood will pool in these vessels, and blood that isn't flowing clot in the vein is very common, called thrombophlebitis, and this clot will then become a solid mass. It will block the rest of the flow, since it's like a plug. And then if you look down below, what will happen is the blood below it will stop, and it will clot. Also, the chemistry is such that the blood above it will clot as well. Clots tend to propagate clots. So what happens to that clot? That clot is sitting there. It is now called a thrombus. It has the possibility to break loose. If you then get up and start walking around, start ambulating, the pressure from these muscles can force that thrombus up into the circulatory system. Well, what's going to happen at that point, if we remember the root, is any lower body thrombus and any brain or upper extremity thrombus is going to get into the circulatory system. Now that it's floating, it's called an embolism or an embolus. Embolus meaning just a floating or circulating thrombus. That thrombus is going to get into the circulatory system, and it's going to progressively meet bigger veins, no matter which direction it's coming from. So there's going to be nothing to stop it on the venous side. It can then go into the heart, still getting to be a bigger vessel. It'll go into the ventricle on the right side, bigger vessel, and then it will be pumped out the very large pulmonary arteries, where it's suddenly going to encounter smaller vessels. So when it gets into the lung and it reaches either arterioles or anything smaller, eventually the capillary bed, it's going to stop. It's going to become lodged there in the lung. That's a pulmonary embolism that occurs from the thrombophlebitis of the leg. It used to happen very commonly when we, in the beginning of the last century, patients were kept in bed after surgery for a week. We were very afraid of moving them around, of having our repairs tear open, so they were kept flat in bed for a week. Their legs were kept flat and inactive for a week, and they would develop these clots in their legs that were probably asymptomatic in many cases. At the end of the week, we'd take them out of bed, drag them out of bed, and help them to walk. And the first thing that happened, they'd take 3 or 4 steps and they go, chest pain, turn blue,